Could you send an invite to Kathy Branson because she can't get in?
I've just done it.
Thank you. So before we get started, just to remind everybody to turn the mics off when they are not speaking so that we get less feedback. This afternoon session is going to be live on YouTube. A bit weird, but modern times. And the chat function has been turned off, so we can't use that for any conversations. And if anybody got any questions, you know, on the papers, it's best practice just to ask it in the meeting anyway. And apart from that, let's hope everything goes well this afternoon. And thanks, Ian, for supporting us.
No problem. We're live on YouTube now, so just so you're all aware, you're all famous as from this very moment.
So is it on the? Is it just the card showing? Is it actually?
It's just a slide and our voices at the moment. So from this point on, you and Sarah will be sharing content if you need to, and when you and Sarah will take down the slide. And then when you speak, Doris, or whenever somebody speaks, they will appear on the screen in front of people.
Brilliant. So I'll turn my mic off till 1:30.
Okay.
Good afternoon, everybody. Welcome to the Norfolk and Waveney CCG Primary Care Commission Community. This is our first attempt at doing a YouTube live stream. So those of us who are joining us on YouTube, welcome you as well. First of all, I just want to remind everybody just to turn the mute button on when you're not speaking, just to make sure that the sound quality is okay for everybody. And I also want to welcome a number of new members to the committee. Rosemary Moore and James Foster have been appointed as practice manager, sitting on the Primary Care Commission committee. James is on holiday, but Rosemary is joining us this afternoon, so welcome. And also Bill Burrett from the Norfolk Health and Wellbeing Board and Tony Goldson from the Suffolk Health Wellbeing Board. Nice to see you both, gentlemen, and your first meeting joining us as well. So hopefully we have an interesting discussion this afternoon, and I will start the meeting. The other thing is that there is no chat function. So if there's any questions, please wave your hands about, and I will attempt to catch you. If I fail to do so, I'm sure somebody will give me a nudge and tell me to look at the right place. We have a number of apologies from Parveen Mercer, James Foster, Tracy Williams, Alex Stewart, Kerry Overton, although Jill Jones is substituting her from Health Watch Suffolk, Kath Byford and Karen Watts. I think that's all the apologies I've got. Declarations of interest. We've got in the pack the declarations of interests for most people. I think there may be one or two missing. Has anybody got anything to declare for this afternoon's meeting? No. And can I just remind those who haven't sent either Sarah or the governance team your conflicts of interests, can I urge you to do so before the next Primary Care Committee meeting? Thank you. Moving on to the minutes, which I will take as read. Are there any points of correction anybody wants to raise? Kathy?
Thank you, Chair. It's item 14 and page 17, the sixth paragraph down. I'm not quite sure what I was saying there, but I didn't say that, I don't think. What I was trying to say was that if staff are able to rotate around between PCNs and services, they're much less likely to burn out, and also it's likely to improve service quality.
Thank you. Amend the minutes to reflect that. Are there any other corrections anybody want to raise? No. So I subject to that amendment, those minutes are fine for signing. Are there anything on actions that is either not on the action log or in the minutes, on the agenda this afternoon? John?
Thank you, Chair. I just didn't want to lose sight of the discussion we had last time about Bowthorpe Care Village, where when we approved the situation for this year, we were keen that there's a longer term solution found for next April. I know it doesn't feature on the action log as such, but I wonder if there's something about maybe having a committee future work plan so that we can plan in longer term issues such as that. Just didn't want to lose sight of it, Chair.
Thank you. We could actually add it onto the action plan with a date for later on in the year, so that's sort of 6 months' time or before the end of the or start of the financial year. Anyway.
That'd be good. Thank you.
See Sadie nodding at me, so it's on her list. Thank you. So we move on to the action list. The blue ones are closed. I've signed the minutes. The risk register was circulated post-meeting, and the financial risk has been added. And and we have on the agenda item the medicines issue. I just wanted to check on there was we did send a response back to LMC with their questions. Are there any follow-up? Is that closed now?
I believe it is, Doris, yes.
So we can close it after the meeting. Thank you. And the workforce is coming to October, so there's nothing outstanding on the action log. And the next page is just all things that have closed previously. So that takes us neatly on to the risk register. Do you want to take us through this, Sadie?
Thank you, Doris. I'm going to assume that people have read the risk register. We are, as you know, this has been an interim risk register, and we've been working on it for the last couple of months. We're going to propose some changes to it for the next meeting to make it perhaps a little bit easier to follow, and learning from what goes on in other committees. So new changes will be that we will add in an overall summary page, so you'll be able to see at a glance how risks are changing, rather than having to go line by line through. Of course, you will be doing that as you're reading through the papers, but at a glance you'll be able to see where you might want to focus your attention. We'll also be making changes to the reference numbers. On the left-hand side, at the moment, we've got the originating CCG references from before we merged, and that was just to provide an audit trail for us as we carried risks through from previous primary care committees into this one. And as you can see, and as was picked up on the action log, we also have the new financial risk added on to the end of the log. So I'm very happy to take questions, and we've got other leads within the meeting today who will be able to pick up on any questions or queries that people may have.
Are there any questions for Sadie from anybody? No, I don't think so. It would be good to see the summaries, and I mean, it's looking at the current risk register. Most of the risks have stayed either the same. There's a few that have gone down, which is always good to see. Mm-hmm. But at the moment, it's quite a mountain to climb to get through it.
Yes.
Hi, John. Did you want to?
Just a couple of brief comments, if I may, Chair. Sorry. On the last page of the risk register, I think it's the last page anyway. There's just for clarity. There's one. It's the first with a TBC reference. There's one that says cost pressures relating to ongoing supply issues. I think just need to make it clear that's medicine supplies as I read it. But the more substantive point probably was a few further down from that. We've got a strategic risk about the impact on primary care of phase 3, as the next stage of the COVID response is called, so the recovery phase. Just conscious that's a huge focus of the system's efforts at the moment. I just wonder if it would be helpful for the committee to have a bit of an update, maybe for the next meeting, on particular pressures and responses to those pressures in respect of phase 3.
Yeah, I think that's a really good suggestion if Doris is in agreement.
Yeah, no, that's good, because we had a paper, we had a discussion last time on remobilisation, so it'd be good to have a follow-up in terms of how things are actually going on the ground, and that probably is a ongoing monitoring that we need to keep an eye on. Are there any other questions? So we'll accept the risk register as currently Noted, and we look forward to seeing further enhancements. Thank you, Sadie. Finance report, are you taking this one, John?
Actually, I'm asking this one. Emma Crean Morris,
Sorry.
the call to present the report. Thank you.
Thanks. Sorry, Emma.
That's all right. Hi, Doris. Thank you, Chair. If I can take the paper as read, please, but leave the committee to the page 1, which is the executive summary. Thank you. Just to say that our financial budgets at the moment in the primary care arena, which is consistent elsewhere, are based on the month 4 allocations. So whilst we're showing here the annual budget for our primary care directorate, this is based on month 4 extrapolated, and we are in the process through a number of submissions of finalising what that position will be with NHSNWCCG. With regards to the year to date, we're showing a spend of 132.6 million, which is 2 million overspent, primarily driven by £750,000 with our GP prescribing, and then another 1 million, which is the net of our delegated primary care and PMS to GMS transition. So this is where the delegated primary care budgets have the money to spend on the PMS to GMS transition, but the spend actually sits within our primary care arena. With regards to the full year forecast, we are showing an overspend of 10.9 million, and you can see 2.2 million of that is coming from our GP prescribing, and the £8 million, same situation as the year to date, the net of our delegated primary care and PMS GMS transition. That £8 million is clearly a large financial risk, and is a risk that's been previously presented to the committee. Is actually shown on a further schedule further down, forgive me, which is the on the schedule 6.0, which is the delegated primary care and PMS GMS risks. So that's just over the £8 million. So to move on to risks, they haven't changed materially since those presented in previous months on schedule 8, financial risks, but it is worth noting that last month we anticipated receiving monies of just over £7 million for GP forward view. They were due in August, but they haven't been received as yet. So we have escalated this to NHSNWCCG and are waiting confirmation of when those monies will come through. And the final update to the committee is just a verbal update of what we've seen on the accounts for August, so the month after this report that's been presented to the committee. It's to say that the prescribing incentives, which are currently showing as a pressure at the start of this report, has been subject to a budget realignment, so that will be able to remove that £500,000 pressure. We've seen some additional pressure in our GP prescribing, some further pressure in our delegated primary care, principally around some estates, but also some additional GP members being added to our GP retention scheme, which is outside the control of the CCG. And the delegated primary care in the region of around about £200,000, and GP prescribing an additional full year pressure, new based on the August position of about an extra £500,000. So again, the key financial risks remain the same. I think it would be helpful when we have our finalised full year allocations to bring back to the chair, if we may, is not just presenting the risk that we are seeing in our delegated primary care position, but also being able to finalise what that risk is and then to present to the committee some of the actions we can do, particularly to look at the things we've addressed as being internal risks of the CCG. A lot of those things arise from mandated increases in spend where the allocations haven't been awarded to the same level. But happy to take any further questions on that if that would be helpful.
Thank you, Emma. Are there any questions? Hein?
Emma, it's Hein. 2 questions. One, the PMS to GMS transition makes a part of the pressures the way I have read it, but I thought it was more an accounting issue that the actual show here whilst the budget shows somewhere else. So is it really a pressure? That's one question. The other question is about locum costs. I understand part of locum costs are being reimbursed because they relate to COVID, but do you have any sight of locum costs that are not COVID driven? Those are my 2 questions.
Thank you. So if I can come back to your first question, if I may, Hein. You're absolutely right. It's an accounting issue. So if the delegated money is awarded within delegated primary care row, are locked down to the CCGs and able to move those budgets around, whereas actually the spend sits in our primary care. So when we look at the page 1 executive summary, whilst you'll see a row that says PMS to GMS transition, that spend, say, sits within our primary care, but the budgets are actually awarded on a separate row, which is the primary care delegated co-commissioning. So again, I think it's more helpful to actually view both of those lines together because it's just where the funding sits. With regards to your second point on locums, I'm afraid to say I can't answer that well for you at the moment, but I'm happy to bring a separate paper or provide an update after this committee, if that would be helpful.
Yeah, thank you.
Thank you.
Any other questions? Just while we have you, Emma, it relates to later on in the agenda, where we talk about PCN funding and the carry forward from last year. It's not obvious to me where's that shown in this, or is not shown in this and it sits somewhere else, because there's like 700,000 carry forward for spend for this year.
So we're happy, we can certainly provide an additional schedule to show the PCN as a separate project, and that's where we are looking for some of the outstanding allocations to come through. So yeah, we'd be happy to provide some additional analysis on that for you. But,
yeah, because at the moment it's sort of, I scratch my head and go, where's that showing in the summary accounts? So if they all can tie in and tie up, sorry, this is the accountant in me speaking. That would be quite helpful.
Yes, certainly. Happy to support and deliver that for you.
Thank you. Are there any other questions for Emma? No, thank you very much for that rattle through of finances. It'd be good to see the actual allocations when they come in, and how we are going to mitigate some of the cost pressures rather than kind of guessing at the moment. So that'd be great. Thank you.
Okay, thank you very much. And if I can now be excused if I may, Chair.
Oh, I think so.
Thank you very much. Bye-bye all.
Thanks, bye. We move on to the estates paper. Sorry, I'm just slowly flicking through my screen. Is Paul presenting this?
Hi, yes, I just joined in time. Thank you.
Thank you. Thanks, Paul. You take the paper as read. Are there anything you want to highlight?
I'll just pull out a few highlights. So the paper is written in two sections. Section A around primary care investments, Section B around rent review process. Section A is then split the investments into funding sources. So hopefully you're all aware of the Way 4B programme, which is now getting back up underway. Within the paper, a note that CCG committed to getting some draft timescales to NHS England by the end of August, which we did. Had some initial feedback on those, and I'm due to take a paper to CCG exec in a couple of weeks' time to go through that feedback and a way forward, which hopefully we can then present back to this committee in a future date. The other sections in there around funding sources, we've got ETTF schemes, which again, hopefully you're aware, but ETTF comes to an end this financial year. So there is a pressure to get all schemes delivered. NHS England have said that although technically the scheme ends, all practices will be allowed to slip projects into 21-22, with all kind of building works having to be completed by December 21. So there's a 9-month extension there. But all business cases, if there are any still outstanding, will have to be approved by March this financial year to be eligible for the funding. And then business as usual capital, we've got 2.1 million this year. Within the paper, I say that we'll prioritise all of these by the 11th of September. Myself and the team we've now done that, and we need to feed back to the primary care locality associate directors to kind of go through those and validate those. So we'll be able to go out to practices within the next week to let them know how they've got on. And then finally, within the paper, talk about rent review process. So we've approved 6 rent reviews in month, but just to flag, we don't see all of the rent reviews that come through for approval. NHS England automatically approve those within a 5% plus or minus. We have now started putting in regular catch-ups with the DV, Rob Butler. We had our first one last week where we focused mainly on investments and his kind of work relating to those. But next month we'll be focusing on rent reviews and these input into those. So we're beginning to get, as a new team, we're beginning to get more regular dialogue with our kind of key stakeholders within the system now, which is really positive. I didn't really want to pick out anything else from the paper, but I'm happy to take any questions on anything.
Thanks, Paul. Questions? Are there any questions from anybody for Paul? No. Just on the main funding, the approval comes from NHSNWCCG. Is that correct?
Yeah. So the general process is for any funding source, the practice will submit a business case or a project initiation document, then outline business case, and then full business case to the CCG. CCG then reviews that internally, and ultimately John Ingham has gives the CCG approval to those. That then has to go to NHS England to kind of also sign off those business cases as well. And that's a monthly process. So John will be receiving this month. We've got 3 business cases to send to John this month, which will go to NHS England at the end of September. It's a little bit of John likes to ask us questions when the business cases come through, so we allow a bit of time to pick anything up before going to NHS England, so hopefully they get a smoother ride at their review.
Many thanks. Bit of Brown is useful. Thank you. There's no other questions for Paul? Oh, John.
Just one thing, if I can. Hi, Paul. It's just making sure that in terms of both developments and the rent review process that we're linked in with future financial planning, because I'm conscious that you don't need too many new premises developments to start to build up quite significant ongoing revenue pressures. So just making sure that we're hooked back into the financial planning.
Yeah, so we've tried to arrange a meeting with Ed and his team and the delegated commissioning finance team to go through that. It was due for last week, but then with planning returns due, that's now been moved to a couple of weeks' time. So we have got something booked in to go through that process. Stuart White gets a lot of this information anyway from delegated reporting, so he should be putting that into his forecasting for the current financial years. I'm not clear on the process of how finance then forecast that going forwards, which is what we want to talk about.
Thank you. I'm just conscious it's an issue in general across the system about it's one thing getting capital funding to support things, but the revenue consequences of that and being able to afford them is something else for provider partners, and it's similar in primary care as well. So pleased to know that we're joined up there. Thank you.
That's great. Thank you. There's no other questions. Thank you very much, Paul, for the summary. It's very helpful, and we look forward to the next report.
Thank you very much.
Thank you. So we move on to the paper on PMS development monies in Norwich. This is a paper for approval. Who's presenting this? Oh, it's Jade.
Yeah.
Great. Thank you.
Thank you. I'll take it as the paper's been read, but I just wanted to highlight some key features of the paper. So what this is actually outlining is we're looking to release 37,400 of PMS funds to One Norwich to help support the reimbursement of IT support for practices within Norwich. The second part of the proposal is for One Norwich to establish with local practices the IT support needed on behalf of PCM. And the third part of it is this is a time-limited piece of work, so a review within the next 12 months to assess the needs for the PCM. As you would see in the paper, Norwich PCN and like many other areas are doing a lot of transformational work in relation to digital solutions, and we're working with the CCG digital team to help achieve what's required to deliver excellent direct patient care, but also to support our practitioners within general practice. PMS funding historically has worked differently when we were 5 separate CCGs, and the paper outlines what this historical arrangement has been in the past. However, under the new Norfolk and Waveney CCG arrangement, it also outlines what steps have to be taken, and this paper has gone through all those processes to be presented today. Part of the proposal has been outlining what type of work would be involved with this dedicated resource to help support GP practices, but also to help support our PCN within our digital landscape. So we're looking at this role would be dedicated resource to help improve improved access, technical solutions such as Eclipse, Protect Now, GP Net, Ardens, and also looking at supporting vulnerable adults in such projects, local projects such as City Reach. The benefits, obviously, the proposal has been outlined, is obviously for our direct patient care, but also clinicians within the PCN. But primarily, it's going to provide additional resilience and support for our PCN with the IT elements. It helps to assess what our demand and capacity requirements to help deliver our PCN requirements. So I'm very happy to answer any other questions, but that's what the paper outlines and the 3 requirements that we're looking for approval for today, please.
Thanks, Jade. Are there any questions? Hein?
Thank you, Chair. Jade, thank you very much. It's not so much the proposal itself that my question is, but it is helpful going forward, because the danger is we see this proposal in isolation and not have sight of what other proposals are in the funnel, what has been approved to date. So I don't know if that's within your remit to provide, or Sadie can whisper in the right person's ear, but have a bit of connection, because I think it also helps us to make a judgment about proposals. That's it, Chair.
John?
Just to comment on that, Hein, I had the same query, and I got hold of a schedule offline, which just enabled me to see that, yes, there is sufficient funding that's not been committed to date to say that this is okay to go ahead. But I agree, I've asked James and the finance team to just hook up offline with Sadie and the team to make sure that any proposals that come forward on PMS funding just show this is what's available, this is what's committed, and this is what's left, so we can see how it fits.
Thanks, John.
Can I just ask briefly as well while I'm on, Jay, just to double check, is this an ongoing recurrent proposal, sorry, or is it a 12-month proposal?
It's a 12-month proposal with a review of the PCM requirements.
Okay, thank you.
Mark?
Thank you, Chair. And just to say, when I first saw a version of this paper, I had several questions as well. So we did have an additional, I did have an additional session with the meeting, with the team, and also with the digital team from the CCG, just to check that we weren't duplicating, this role wouldn't duplicate current existing resources. And it does have the support of Anne Heath as well, and how this role will link with her team as well. So just to support that we have done that additional piece too.
Thank you. Are there any other comments, questions?
Can anyone hear me? It's Naomi Woodhouse from the LMC.
Yep.
Oh.
Sorry, we lost you. Naomi?
Apologies. Can you hear me?
Yep.
Oh, apologies. I've got microphone issues. Yeah, just so we have fed back some comments to the practices and fully support the bid. We just wanted to make sure that there's going to be no duplication in this role and any potential new staffing roles in the CCG digital team to ensure that there's no double payment.
Yeah, no, thank you. Was there any other comments from anybody? Thank you. So are we happy, Kathy, Hein and John, to approve this? Yes, I can see heads nodding at me. Brilliant. So that's been approved. Thank you very much, Jade.
Thank you.
Moving on to PCN additional roles, the reimbursement scheme on the next paper, number 9 on the agenda.
Hi, yes, Sally Ross-Bellum here. So I'm going to talk to west, south and north elements of this. And I think Jade is going to talk to the Norwich piece of this. Is that correct, Jade? Okay.
That's correct. Thanks, Sally.
I'll just quickly cover off anything around the other 3 areas. So yeah, we'll take the paper as read. There are a number of posts under the national DES for the primary care networks, and first contact physio and pharmacy technicians have been particularly popular in the planning for workforce in all west, south and Norfolk areas. So the ask is that we approve some flexibility around the total numbers of these posts in each area. That is allowable under the DES if it has permission from the CCG. It is, of course, within the limits of the budgets that are available for each of these areas for additional roles. So it's just a request for each of our flexibility. Pharmacy technicians are really viewed as valuable in terms of supplementing the work that's been done to date to the clinical pharmacists, and the physiotherapists are already having quite an impact where they have been employed, and the benefit for GPs in terms of the time that's saved by being able to have patients go directly to physios instead of come to them has also started to have an impact. So it's really trying to build on that in terms of the workforce plans and a request that we can have some flexibility signed off here to enable them to carry on. Do you want me to hand over to Jade now to do the Norwich elements and any questions, or did you want any questions now?
Let's do both together.
Thanks, Sally. So as you may recall, I presented a similar position at the last PCC meeting. So we've done another review since that proposal in May. And what we've also done is done another assessment based on our PCN needs, but also our demand and capacity. Previously, we have had approval to recruit above. So previously in the May meeting, we got approval for 4 first contact physios and 4 pharmacy technicians. Today, we're looking to enhance that by increasing it for a further 1 additional pharmacy technician. So that would give our allocation to 5 pharmacy technicians for Norwich. And we're looking to increase another 4 first contact physios. So that would be a grand total of 8 first contact physios for Norwich PCN. In the pack, you will see what our workforce plan is like. So based on that, we're looking to, if today is approved, that will give Norwich PCN a grand total of 34 additional roles within our neighbourhood and also our dispatching across the PCN as a whole.
Thank you very much for the summary. Are there any questions for Sally and Jade from anybody? John?
Thank you. Just testing my understanding, I suppose. If we're saying that the extra roles are still within the sum that's available, are we saying therefore that we'll be having less of other roles, or was it just that there was spare funding within that sum that was available?
It will be. It's a decision by the PCN as to what roles they want. So yes, there will potentially be less other roles because they've picked these roles. So yeah, they won't. It's always the choice of the PCN what they feel will reflect the needs of their population most. Have you got some concerns, John, about particular posts not being recruited to?
No, not really, Sally. No, it was just, I suppose, understanding any risks or disbenefits that might happen from approving this today about these extra roles, recognising that this is what the PCNs are looking to do. So it seems sensible, but it's just understanding any consequences of that, I suppose, on other roles.
So, do you want to come in on that?
I was just going to add that each PCN now, the additional roles reimbursement scheme is on a capitation basis. So the amount that they have available to them is reflected of the total registered list size. So the proportion of roles is slightly different in each PCN because they're responding to what they feel their population needs and how they will deliver the PCN service specs, but the overall capitation funding limit remains the same regardless.
Thank you. Are there any other questions? Oh, Michael's was there.
Just a comment. There's plans for 4 dietitians, I see, and just to say the availability of dietitians is actually very low at the moment, and there is a shortage in secondary care. So you just need to be mindful of a strategic vision across the ICS, so as not to destabilise overall provision. Okay.
Thank you.
Thanks.
Kathy?
Yeah, it was more a question about outcomes, really. I mean, I absolutely agree with Michael's point about not stealing from Peter to pay Paul. But the other thing is that experience shows that new roles are kind of relatively easy to develop and recruit to, and really hard to integrate into the existing workforce in order to make them really effective. And I wonder whether, you know, when we have the PCN reports going forward, whether, as well as saying we've got this many new roles, to say service is changing in this way and patient outcomes are benefiting in this manner, because I think, you know, that's where I can make a judgment about whether it's value for money or not.
Thank you.
I completely agree with that. I think that's really important going forward. And I think some of that will be reflected in the focus bits that come up later on the PCNs. But yeah, that is absolutely key.
Jade?
And that part of our evaluation, while we've now come forward, is we've evaluated what the benefit has been of those additional roles that we've recruited in May. So we can actually see from a Norwich perspective, the demand and capacity need from patients. So we're doing that as part of our evaluation process to look at what else is required for the PCN based on those additional roles. So that's why we're asking for an increase from today.
Thank you. John Webster?
It's just extending the point really around the opportunity cost of some of this approach, I suppose. So I just wondered if I'm missing the point in the table, but I'm looking at a plan for 9 clinical pharmacists within this financial year. And then in the following financial year, 21-22, is it that there will still be 9? It's just I can't see anything written in that table. So I was just concerned that just around the clinical pharmacy import, I'm probably just reading this table completely wrongly, but I'd just like to be reassured that I am.
Sorry, so the table that you're looking at is the Norwich one, so it isn't, you know, looking at what Sally is putting on behalf of the others. So you're absolutely right, John. It's based on the financial year of the contracts in place. So that's why we've got to spend within our financial gaps within our limitations. So we are intending to have those clinical pharmacists still in place for 21, depending when we get the new funding through from NHS and for those additional roles. So that has been in consideration within our overall picture.
That's really helpful. Thanks, Jade. And I suppose the follow-on point for me was just around making sure we are protecting the mental health practitioners within the PCNs as well, and that there's not an impact on that. If you could just confirm that, thanks.
Yes, so we're very much working in partnership with an FST and obviously another assistant partners, particularly around our community pharmacists, because we don't want to destabilise any of the system. So we are very much working with Sadie's team and establishing those links within our additional workforce roles.
Thanks so much, Jade. Thank you. Thanks, Chair.
John?
So if I can, it might be going over something you've already said effectively, but building on those points and Michael's point, first contact physios as well, conscious that therapists will have a significant role to play in supporting discharge from hospitals, helping the phase 3 recovery. Does this tie into the overall system view of workforce and priorities for workforce over the next 12 months or so? Because I'm conscious the pool that we'll be recruiting is likely to be the pool of existing people, presumably.
Can I comment on that? Because I think I asked this question at a previous meeting and I was told that they were coming from a private provider in the main. So they're already in existence. We're not taking new staff from the hospitals or the community trust.
Sally, do you want to come in?
It's Pure Physio who have subcontract to from a Norwich perspective. You're correct, Kathy.
Sally, you're on mute.
Sorry, I think there is always going to be a tension between what's happening in different parts of the system. Primary care networks have been tasked with building up their primary care networks, building up support for the work that they're experiencing today and what they're doing. These are the posts that they've been advised to recruit to. And I absolutely agree, there is a tension there, and we do need to work together to try and mitigate that. And it's a complex environment within which we're trying to do that, with the new structure, with the COVID impact. And we're reliant on our strategic colleagues, I suppose, to support us. I am trying to keep everybody aware of what's happening, but at the end of the day, this is a national enhanced service that practices are given the funding to be able to expand their workforces on to deliver the work in primary care today. So it's how do we make sure that we have that balance right across the whole system at this point in time?
The $1 million question. Thank you. Are there any other? Mark?
So just in relation to that, I think, I mean, it's far broader than this meeting and this group, of course, but I think there is something about, and we've talked before about how do we make Norfolk and Waveney a really attractive place to live and work. And I think that's, something that we can really build on with NHS and council colleagues to, I have this vision of every advert that we put out, every pack that goes out has this is why Norfolk and Waveney is brilliant and you want to be here, to really encourage people to come into Norfolk. And I know there's plenty of work going on with that, but I think that, these things need to be done in parallel, don't they, with all of this?
Hi, Doris, it's Naomi Woodhouse. Can you hear me?
Yes.
Just building on what Sally and what Mark have just said, I mean, the numbers were set nationally based on a workforce analysis of how many of each specialty were available. So there is always going to be a case of sort of sharing of staff, for want of a better word. So just wondering if there was any work locally to try and either increase the training opportunities for these roles or to do any sort of combined work with other providers to help support PCNs to recruit to these roles, but also ensure that those roles are able to support other areas where required. And also the fact that when these new roles come in, they don't hit the ground running. There is an awful lot of integration needed and of training requirements. And whilst there are national training programs, the time taken is more integrating them into the team and the local system. And so it's about making sure there's support for PCNs for the staff members once recruited, not just to recruit them.
Thank you. Sadie, do you want to respond to that?
Thank you, Chair. I think Naomi raises some really good points, and I just wanted to make members aware that this year we have enhanced funding for our training hub function, and a big focus of the training hub going forward is supporting new roles, supporting workforce development, growing our own, and really building on the foundations that we have already. Obviously, some of that work had to be paused during the initial response to the pandemic, but it's really starting to build again now. So we're working very closely with the university, engaging with the locality teams and PCNs. We intend to refresh our training needs analysis, which we undertook about 11 months ago, because things have changed so much since then, and working lives are very different now than they were even a few months ago. So we are focusing on that. And perhaps it would be good in our next workforce report to start focusing on some of the detail around some of this, so that you can see how that whole programme links together. We are working also very hard to bring together the work that we're doing around primary care, which we're accountable largely to NHS England and Improvement and Health Education England for, because that's where we get the funding from, alongside the wider system workforce development, which is being led by Anna Morgan, which focuses on all of the other providers in our system, because there are such opportunities now as we begin to integrate services around local populations to bring together those two programmes of work much more. So we'll try and bring a report alongside, I can't remember from the forward planner when the next workforce paper is due, but we'll do a particular focus on the additional role scheme and PCN development.
Thank you, Sadie. Are there any other questions, comments? So can I ask John, Hein and Kathy, are we happy to approve the recommendation to change the numbers? Yep, brilliant. Thank you all very much. So that's approved as well. Thank you. Moving on to item 10, the prescribing quality scheme. I think Lois has joined us. Do you want to just give us the highlights of your paper?
Thank you, Chair. Yes, so the prescribing quality scheme is developed every year and it's there to help incentivise improvements in areas of prescribing, namely quality areas. Previously, each CCG in Norfolk and Waveney had a different scheme in place and different money attached to it. So all 5 CCGs except for GYW had a maximum payment of 80p per patient attached to previous schemes. GYW had a maximum payment of £1.80. So as a result of COVID-19, our scheme wasn't launched in April like it would ordinarily, but we've now agreed with the LNC that it's time to progress with the scheme for the remainder of the year. The indicators all focus on engagement and quality. I'm not going to go through those, they're in the appendix. Proposed funding methodology. So obviously there was a bit of a problem given that we had different mechanisms of payment for all areas and we needed to standardise that this year. So it's proposed that we offer practices a £1.80 pro rata payment that would equate to £1 per patient for the remainder of this year. The methodology takes into account the following things: the fact that we are now one CCG, so we need to be equitable in what we're offering. Practices only have 6 months to deliver this scheme, so we have to be realistic about the volume of work they're going to be able to deliver. The intention pre-COVID was to allow practices to have a £1.80 per patient payment, but obviously we're now way past April. It's also important to note that the Department of Health and Social Care guidance has previously advised on what monies can be spent on that are achieved via an incentive scheme. And they're quite clear that that's not for recurrent staff funding. It should be on non-recurrent staff funding, or it can be on items for practices such as, chairs for waiting rooms. So it's not part of baseline income. The proposed £1 per patient payment that we're offering would see an in-year increase of 20p per patient for all localities except for Great Yarmouth and Waveney. Great Yarmouth and Waveney previously had the £1.80, so they would see a reduction. So it's important to point out that there would be practices that in Great Yarmouth and Waveney who would ordinarily achieve very highly on the incentive scheme, and these are listed in the table, table 1.5. So these practices are potentially going to lose out on income they might have achieved had we set the £1.80 maximum this year. However, other points that are important to note: practices have not been asked to carry out any work for PQS from April, obviously, because we paused the scheme. We believe the scheme is achievable and it's manageable. There's been a lot of dialogue with GPs on the indicators, and I believe it's fair. GYW, although losing out this year on their potential income, they have had access to considerably more income than other areas for a couple of years. If this is approved, we'll have to agree some careful messaging out to our practices to make it clear why we've come to the decision, why we're doing the part-year scheme, etc. So I would like to recommend that the committee approve this methodology.
Thank you, Lois. Are there any questions to Lewis on this? John?
It's not a question on the funding as such. I'm happy to support the funding. It's, I suppose, the evaluation of it, 'cause I'm conscious that we're asking to approve spend of up to £1 million for something where we've got quantified benefits of potentially 300,000 related to Optimise RX. But the paper does also talk about other areas where there's potential cost efficiencies, potential reduced emissions. It's look at DOACs and other areas of describing where we know there's increased demand. So I suppose it's probably more a question of how do we propose to evaluate the impact of the scheme to then understand what benefits it has delivered, so we can understand whether or not to pursue similar schemes in the future.
So with all the indicators, all the specific quality indicators, practices will need to demonstrate that they've made a change, and most of that we can actually monitor centrally through various systems we have. So we should be able to give some approximations of maybe admissions we could have saved, those sorts of quality impact things. And I think we need to be looking at the wider impact of prescribing changes. Ordinarily, you know, it's not just about switching X to Y. If we can do bigger things, if we can improve quality and we can reduce admissions, then the saving is elsewhere in the system, but it's still an important saving. So we will be able to monitor the impact this will have, and this could be brought back to the group.
Thanks, Lois. Tony?
Thank you, Chair. When you're doing these calculations and these analyses, are you taking into consideration the demographic changes, the age groups? Because in some areas around here, they're 32 to 34% over 65 now, which obviously wouldn't make an impact.
We do, and it's important when we get the views of the locality GPs that that's sort of all fed in. I mean, with all of these indicators, we have looked at the workload that would be attributed to them. So we're clear on sort of numbers of patients that would be impacted by all these changes. So yes, we do try and take in as much as we can, as much information as we can.
Thank you.
Hi Doris, it's Naomi from the LMC. I did circulate some comments that my colleague Joni, who has been liaising with CCG on this, has made, which are still outstanding in a response. I just wondered if it would be possible to have any feedback or response to those specific queries for the group to be aware of before making any decision.
Yep. Because the email arrived sort of.
Yeah, apologies for the short notice.
An hour before the meeting. So have you had a chance, has anybody had a chance to have a look at the comments and make a response?
I would be happy to go through them with a response, Doris.
Thank you, Lois.
So point one. So I think there's an issue with regard to whether the money is attributed to PQS or part of baseline income, which we don't agree on. It's been clear with our schemes that the monies can be spent on certain items, but not for normal staffing costs. So they should never have been attributed to baseline income. Practices have only 6.5 months left to do the work. Yes, we acknowledge that, and the scheme, I think, is proportionate. I think it is something that can be achieved in that time frame. Certainly that's the view of our GPs that we've consulted with. Regarding funding, there was a specific comment about meeting attendance, and that was one of the indicators, and that the payment would be unfair to smaller practices. I'm very happy to review that specific indicator, and we can slightly tweak the payment attached to that to make it fairer for all practices. Was there anything else specific, Naomi?
So really the only outstanding bits are, one, if there's going to be support in line with the other LCSs, that if COVID, for example, or the implications of shortage of workforce or the flu campaign means that practices would not be able to complete this, whether there will be income protection provided to them. and also with the shorter time periods, what support there may be available via the CCG to support practices in delivering this?
I'd like to pick up specifically around CCG support for delivery. So there is a lack of resource, I would say, within the CCG to support delivery, but practice pharmacists generally support delivery of these items. We will, wherever possible, make it as easy by providing searches where we can, providing guidance, education, etc. We're happy to deliver all of that, but we can't do the actual work itself. That needs to be done by the practices.
John.
I'm just going to comment on the protection of income issue that Naomi raised and that Lois touched on as well. I think we do have a clear view within the CCG that this is different. Commissioned services where we, as an NHS, we proactively commission a service from practices on an ongoing basis, and practices employ staff to provide those services. Clearly, you've got staff costs, you need funding to support that. This is different because it used to be called an incentive scheme, didn't it? It was there as additional payments for achieving certain improvements in prescribing, and that extra money was always meant to be spent on extra things for practices, and Lois mentioned a few things earlier, so it was never there to cover ongoing costs of running a practice, so that there are no elements of practice cost, as far as we're aware, that should require protecting because of this scheme particularly, and that's why we're not proposing to have any kind of income guarantee for practice on this. It's always meant to be additional funding for additional items. And I would also final comment on that is that I think I would hope the committee feels that the CCG has been very supportive and fair to practices over the period of COVID. We have financially supported during that period, and for instance, the PPE operation we've had up and running for some time now to support practices. So it's not at all that we're not supportive of practices, because we just think this is the right approach for this particular issue.
Thanks, John. I just have one question on the 1 million potential spend. Is that included in the finance paper, the overspend number that Emma talked to us about earlier?
Shall I comment on that, Doris? Yeah, so the intelligence I've been given is that the budget that we've got for this is £700,000 or £800,000. It's not the extent of the full 1 million, but equally history shows that all practices never are able to do everything that they need under the scheme, so there's never 100% achievement. I'm comfortable as it stands that we've got sufficient budget to cover what we would expect roughly the delivery to be under the scheme.
Thanks, John. Are there any other questions? Are we happy, Hein, Kathy and John, to approve as set out in the papers of £1 per patient as a pro rata?
Yeah, I'm happy with that. I would pick up on John's earlier point that somewhere in the action list or future schedule, we find at the right moment feedback on how this scheme has worked out, also before we make, before we're asked to approve whatever next year will bring in terms of schedule.
Great, thank you very much. So that's been approved, and it would like good to have a feedback later on before the next one rolls for 21-22. Thank you. Moving on to medicines management report. I think, Michael, you're taking us this through for noting.
Yep, thank you, Chair. So this is our monthly report, and this time we were asked to focus particularly on anxiolytics and benzodiazepines, because that's a quality concern for the CCG. But I'll just highlight a couple of things. Section 2.5 talks about the concessions and NCSO, which is no cheaper stock obtainable. So when there's shortages of medicines, the price effectively goes up because we're in a global market and almost a stock exchange of medicines. So that is 2.8 million cost pressure for the year to the end of August. Some of those are estimated because we only have real data up till June. One other issue has raised its head recently, which is lithium, which is estimated to cost the NHS £20 million in the next year, and that will be ongoing because we're in a global market. There was a generic company which owned one of the brands, Essential Pharma. Camcolet was a more expensive brand. They've now purchased the cheaper brand and are now declared their intention to discontinue the cheaper brand in favour of the more expensive brand. And as I say, that will cost the NHS £20 million. The company is actually owned by a Swiss investment bank. And this is perhaps the way forward for generic medicines to a certain extent. So just to make you aware, there's some issues with that. Antibiotic prescribing is relatively good news. The CCG, Norfolk and Waveney, is slightly above on percentage of broad spectrum antibiotics, which is a risk in terms of, if we were very high on them, would be a risk in terms of resistance, particularly to antibiotics going forward. And we're slightly below our volume of antibiotics, so how many antibacterial prescriptions we give to our patients, we're slightly below. But as you can see, I've broken it down by PCN there, so you can see wide variation. So for instance, Swaffham and Downham are very high prescribers of broad spectrum antibiotics, and West Norfolk Coastal are above the old target, whereas most of our practices are below that target in terms of volume of antibiotics. Dependence forming medicines, which is what we talked about last time, and we've got a key focus on hypnotics and anxiolytics. We only had national benchmarking data for May in this paper. So we were 33rd in May on high dose opiates, we're now 36th, so we're going in the right direction there. Gabapentinoids, we were 14th, we're now 15th, so slight improvement. Hypnotics and anxiolytics, we're still 3rd in June data, and we were in May, so hence we're focusing some attention on that, and we've my colleague Lois, who leads on quality and prescribing, will perhaps take us through the plans that have been developed to address that issue. Lois? Oh, you're on mute.
Hi. Right, yes, so hypnotics. In particular, we are a really bad outlier on. We've set up a working group that will specifically look at dependence forming medications, and initially will focus on hypnotics. This will form clinicians from primary care and from NSFT initially, and if we need to involve the trusts, we will, but we think the trusts aren't actually the main drivers for hypnotic prescribing currently. We also need to identify all the drivers. I think a key driver is the lack of non-drug services to refer these patients to. So GPs end up prescribing because there's a lack of alternative provision. So a really important point will be establishing exactly what services there are out there for patients, and what we maybe need. We've developed a pharmacy strategy. It's not quite finished yet, for the whole of the STP, involving all providers, and improving our performance on hypnotics as well as other dependence-forming medications is a key priority for us. So we will have a clear implementation plan for that, and we'll be tracking it every month. What we do know is that some practices are doing a brilliant job of addressing dependence-forming medications, and we all need to learn from that. So we need to share the good practices out there with other practices. So East Norfolk Medical Practice, for example, have done a huge amount of work on reducing their prescribing of DFMs. And it's really important we share that learning with all our other localities. So that's what we'll be working on. It will obviously form part of the agenda for our locality meetings. We're also setting up networks for our PCN and practice pharmacists, so we can discuss topics such as these, sharing good practice, learning. So there's a variety of measures that we'll be implementing to reduce this, and it would be helpful if we could provide regular updates to this committee to keep track of this programme of work, because it's complex, it's not going to be easy, just like opiates. But there are lots of actions being taken, which we'll be happy to report on.
Just by way of finishing off, so Appendix 1, 2 and 3 shows the various positions of some practices across the STP on dependence-forming medicines. And perhaps next month we'll do a focus on antibiotics, because there's clearly some differences across the patch in terms of prescribing. So we'll highlight some practices and some best practice. Thanks. Any questions?
Tony?
Thank you. Very interesting update, Michael. I was grinning when you were talking about the lithium, unfortunately. I take it there's got to be no pressure on GPs and psychiatrists to reduce the lithium prescribing. That's the effect lithium has long term on those who are obviously dual diagnosis.
No, we've been in discussions with our mental health colleagues and psychiatrists and mental health pharmacists, and there's no intention to do any of that. It is an opportunity to review patients, and there will be some patients who may not need lithium anymore, particularly patients with severe dementia who are still on lithium. Don't benefit from it and should be taken off, and we've all agreed on that. There's no intention. It's an opportunity if somebody's been on lithium for a long time to perhaps consider a different mood stabilizing drug, but there's no, that's an individual decision between a specialist and the patient. Largely, there's no drive to change people lithium arbitrarily. Absolutely not.
Thank you, Mark.
Hein?
Yeah, question as you mentioned one of the potential drivers is lack of alternative provision. Can you expand a bit on that? What you mean with that, or potential solutions maybe?
So it's like social options and CBT possibly, or wellbeing services. So, for example, insomnia. Do we have enough services that we can signpost patients to that GPs can use rather than giving them a 2-week supply of a hypnotic, for example? We want to stop the initial prescription if we can, and signpost patients elsewhere to get wellbeing advice, especially for problems like insomnia or anxiety. So it's really looking at that, and I'll be meeting with Jo Yellen from Mental Health to establish exactly what services we do have out there and where there might be gaps, what we might need to do.
Any other questions, John?
A couple of questions, if I may, just following on from that one. Is there a link here to some of the extra roles we were talking about before for PCNs? Because PCN mental health workers, will they have a part to play in this? And also, I suppose, just a brief understanding of the impact on patients of having a dependence on hypnotics and what impact that might have on usage of other services. Because I'm assuming that whilst this is focused on quality and patient care, it does impact on other services as well across the patch, I would assume.
So just going back to your first point, John, re-additional roles in PCNs, yes, I think they have a really crucial role to play. And if we look back at the East Norfolk model that's worked, they've used their social prescriber as a key role in helping patients, actually, again, to signpost them to help that's already out there. So yes, definitely a role for these people to play. Secondly, impact on other services. I think we know that there's significant side effects and problems with people taking these medications year on year, and mental health issues contributing. So if we can't get people onto the right treatment early, they're going to have knock-on effects and use many providers, because their needs are going to become greater and greater as the side effects increase. We're not dealing with the problem if we just keep dishing out tablets. We need to have services that can help sort the actual problem out, and where possible, not provide medication, provide something alternative that's a longer term solution for them.
Thank you. Are there any other questions? Kathy?
There are a couple of practices whose name come up in more than one of the 3 appendices. And I guess that gave me start thinking about the demographics of that practice, and are they in a city, and you've already talked about what other services we wrap around and social prescribing, but I guess there's a real opportunity for kind of a health improvement kind of community development approach around some areas who are kind of trapped in this, trying to manage a population that they just don't have the services for.
Absolutely, and the specific practices that are real outliers, particularly in one or more areas, we will be meeting with those and taking our GP prescribing advisor lead. It's really important they have a very transparent peer-to-peer conversation where they identify the drivers that they're seeing, which we might not be sighted on at all, but we need to be aware of. Yeah.
Thank you. Are there any other questions from anybody else? No, thank you. That's very helpful, and we look forward to antibiotics. I think we've had some conversations elsewhere as to whether that is actually likely to go up, given how patients are being seen at the moment. So, more excitement to come. Thank you for your great work. Thank you.
Thank you.
Moving on to the locality and the PCN paper, which has a lot of information in it. I have to admit I had to scratch my head a bit when I was reading it. So Sadie or Sally, enlighten us.
Perhaps if I start off and then hand over to Sally for the focused presentation on North Norfolk. So just to reassure everybody, we are going to be providing a more focused report in future. We've had a lot of information to catch you all up on in terms of the PCN development work and the locality work. Just a couple of points. Clearly, we've had to put a pause on some of the work that we were doing pre-pandemic, but we are now considering how we can restart some of that in the new digital environment. So thinking about the previous work we were doing on the maturity matrix and the investment in PCN development that we had received. And we have also now had confirmation from NHS England and Improvement that we will have further PCN development funding this year to support them in the work that they are doing to try and move through the maturity matrix and to respond to those elements of must-dos that Kate has set out in the paper. So we expect to be able to, in future reports, bring some more information on how we're going to be doing that and what our proposals are working with the PCNs. But other than that, I'm going to take the paper as read and hand over to Sally for the locality specific update on North Norfolk.
You're muted.
Apologies. If I could perhaps take you to the slide deck, which starts on page 141, if that's not too painful. And I obviously will take everything as read, but we'll try and just pick out some salient points. So starting with the first slide, you've got some illustration of the area, the rurality of the area that's being covered and the spread of the PCNs. And on the next slide, we indicate the challenges specific to North Norfolk. I think on top of that, it's really important to understand the challenges around setting up the primary care networks. We had 19 practices that were very happy to work together. And we have a provider organisation that's sat over the top to be able to help with anything needed to be delivered at scale. With the DES coming along, the practices were quite keen to stay as one primary care network, but we work with them to understand actually, because there was a lot of groupings of community staff and other providers around groups of practices, it actually made sense for them to look at working together locally. And now here we are, some time on and having experienced COVID. And I think the practices are working together really well as primary care networks. They meet regularly, and they work with North Norfolk Primary Care to support them in terms of recruiting to new posts and hosting those posts and supporting the training and the supervision around those posts. One of the challenges has been engagement, because we have changed our structure and we had a very engaged council of members in North Norfolk, and that was really missing, I think, over as the restructure took place and things ceased and COVID took over. So we've restarted what's now called the Primary Care Development Group. So all practices are still able to come together, including their clinical directors, and we're able to share with them pathways and be able to share across PCNs what work they've been up to, what the different schemes are delivering in their areas. We meet weekly with the practice managers from each of the practices as well. We have a forum so they can share. So we sort of have a mix. We're able to work as primary care networks where we need to, but we're also able to share across a wider network of the 19 practices and to utilise their at-scale provider where they want to have some support with managing some of the issues around recruitment and holding contracts. It helps with the legalities to have that body to be able to support that. So if we just move on then to the clinical directors, there's a lot there around how the clinical directors are engaging. I also wanted to highlight our local delivery group at this point, just to say that although it may not be called the local delivery group in the future, we've always found that kind of locality forum really useful. We've got a chair in the form of Linda Hunter from the hospital. We have Health Watch attending. All the providers represented there from the Mental Health Trust, from the community provider, county councils, district councils, voluntary sector. It's really helpful with a wider primary care network development and an oversight of a programme of work which we're trying to develop. So we've managed to get a local flu group of members from the committee or members from the group to support. We had for example, early cancer diagnosis, that's a challenge for primary care networks. So we had a presentation from the NNN on what they're doing around cancer diagnosis. We're also working to get a remit for a task and finish group, utilising the colleagues in the locality forum to be able to look at how can we spread the word around screening, how can we get people to take up the opportunities that are available for them, how can we communicate that, how can we improve the rates. So those are the sorts of things we're trying to work up locally. And then with a view, obviously, to what's happening strategically, to be able to link into those groups that are set up and working across the patch. And in delivering what matters to networks, there are some examples there in the next few slides. I think it's important to note there are some challenges. We have, we're not without practices that are facing issues around resilience. We have a particular issue in NN2 with Chroma, who is a requires improvement practice, and although it has had an excellent plan to get it back on track, it has been thwarted by some internal issues and been able to deliver that. So our delegated commissioning team, I'm saying, has been really supportive in going out and working with the practice, and is currently has drawn up a plan with them. So that impacts the primary care network, but it doesn't stop it from still working together and supporting each other. The practice has been very engaged with all the support that's been offered, and I think that's a really important point to note. It's reached out and asked for support. And then just to finally draw your attention to some of the work around the additional roles, which is on slide 150. So the clinical pharmacists have been undertaking joint reviews of patients who until now have been difficult to wean off high-dose opiates. The pharmacists have had a really good relationship, or developing good relationships with the patients locally, and it's led to better compliance, is what I'm informed by the PCNs. Additionally, during COVID, when palliative care anticipatory drugs were in short supply, they were able to advise on alternatives to their PCNs. In the first 3 months of operation in NN4, the first contact physios have seen and completed care for over 200 patients, largely remotely, which has had a really good impact on the GPs in that area. And social prescribers, that's a developing service. Well, I say developing, it's been around in North Norfolk for some time, the integrated care coordinators, but it's widening out. We've just had a report back from, which Norwich will also have had, because we share some, the district council provision, and it's shown a really good uptake and really good usage of the service, but we need to explore further to see, taking on the point about, so what will all this work? We're actually starting to get some data back now to start making decisions about what are the type of services that are being accessed, how can we refine that? Do we need to have more of that type of service? How can we look at what's going into the practices, what's coming out of the practices, what's coming out of the hospital? So those were the key points that I just wanted to draw out. I'm happy to answer any questions.
Thank you very much. Any questions for either Sally or Sadie? You stunned us into silence. Kathy. Sorry, you're mute, Kathy.
I actually muted myself in order to speak, sorry. Thank you. I thought it was a really helpful report. It actually asked some of the questions that we've raised in previous papers, so it's beginning to tie it together, which I thought was really helpful. I had two questions, actually. One question was about the role of the clinical director. It's a new role and then new in role. And I see that, you know, when you had a new person take over, they got some induction from the previous incumbent. But I'm just wondering, is there a development programme for those people in those new roles, thinking about the art of the possible? Do they have kind of national networks or something of that nature? And my second question is, you referenced community nursing, which is great. You don't mention health visiting, and having spoken to a few primary care colleagues, they tell me that health visiting is, their access to health visitors is not what it was at all, and they wish that we could develop better relationships across that service. So those are my questions.
Thank you, Kathy. So I think the development of the clinical directors, I think there are plans in the maturity matrix and the development funding to support the clinical directors. I think COVID has put some of this on hold. It is a really important point and does need to be put in place. I'm sure the training hub itself is looking at how this can be achieved. We will be working, especially now with the experience and hindsight of COVID and the work they've done to date, to see what they would most benefit from. I know some of the key areas that they've asked for in their primary care development funding usage is to have champions as well as themselves, you know, to have nurses, to have managers, to be able to support with some of the load of primary care networks and to share the development work. I think that will perhaps free up their time to be able to, free up their time. It will hopefully enable them to be able to take part more in some developmental role for themselves. I think that they're very much seeing themselves as being the sort of voice for their practice, and I was starting to gain in confidence and in and starting to see that actually their relationship with their practices is not, you know, people won't get upset if they go off and say, I'm speaking on behalf of my primary care network. That's been a big, because they see themselves, we're all practices together. So now I think that leadership role is starting to be, they're starting to seem to have it. I think now is a really good time to go in and offer them some very bespoke training around that. But I'll speak with Sadie and the training hub to see what we actually, I'm sure that's, I don't know, Sadie, if you wanted to come in there at all around CV development or.
So you asked about networks as well, Kathy, for clinical directors, and I think pre-COVID, the East of England regional team had reached out to clinical directors, and to be perfectly honest, in the first few months they were absolutely bombarded with offers of training, and it was very difficult to pick our way through all of that. The training hub has been linked in. I think actually, I was just, as Sally was talking, I think there's a real opportunity for us as we refresh our training needs analysis to do a really focused piece on clinical directors now that they've been in post for 12 months. And well, some of them are still quite new as we've had changes. They should have a better idea of what their needs are. And of course, each of the PCNs developed their own development plan. which each had a focus on clinical directors. But again, you know, their experience of the past 6 months or so might well have changed what they thought their needs were. So I think there is a real opportunity to refresh that now.
Hi, Doris. It's Naomi Woodhouse from the LMC. Just to add into that, there is a BMA has a national network for clinical directors, which has a forum which a lot of them are very heavily involved in, but it also provides a lot of training and support, which we have advertised to practices and can do again, but would welcome the committee to be aware of this. But also just wanted to raise some feedback that we've had from clinical directors is that they are finding that the role has developed exponentially recently and some of the workload is becoming overwhelming. And so there definitely does need to be an awful lot of support for those GPs to enable them to maintain that role and be supported in it and fully trained in what it is they're being asked to do, because so much is now falling on PCNs that we first of all need to make sure it's all appropriate what's going to PCNs, but also that the clinical directors have been given the tools and support to deliver their role as clinical director on behalf of their PCN.
Thank you. Sorry, yes.
There was a second question about health visiting, and just to say that is a really good point, Kathy. So I will take that away and I'll look into that and see how we make that engagement happen. Thank you.
Are there any other questions? John?
Thank you. It's really good to hear all the work that's happening in North Norfolk, and there's a number of good priorities around supporting mental health and community services and the Chroma Dart and things like that. I'm interested though, within North Norfolk, do the PCNs see themselves having a role in supporting the resilience and sustainability of individual practices within the PCNs? I'm just conscious, tying back to our risk register, that's one of our key risks, isn't it? Workforce gaps, resilience issues. Just interested what role the PCNs see themselves having in supporting practices.
So I think there were some really good examples of that through COVID, where practices weren't necessarily able to open their front doors. And we've had two options. We've been very lucky. So in some cases, practices have been able to help each other. They've been able to actually provide rooms for the practice to move into, to be able to operate from, for patients to come to. And then we've also had the provider organisation, NMPC, be able to step in and provide additional clinical resource from some of the schemes that it runs for the practices to support them to stay open. So there's been two different ways that that's been demonstrated. I think in terms of there being, I think the relationships between the practices in each PCN are developing. This has helped those relationships to develop. So now I think people feel more comfortable ringing each other up, and particularly with the COVID experience now, I say to ring up and ask for help. I don't think there's a blueprint as such. If this happens, this will happen. I don't think we're quite at that point yet, and that might kill off where we are. Sort of, we've got the roots of that happening. If we were to try and really put a plan in place for that now, that was too big a plan as such. If I'm articulating that very well. But I suppose what I'm saying is, yes, it's there. Yes, it's developing, and yeah, we do need to tap. We need to bring it along. We need to tap into it, and we need to get to a point where we can articulate it as part of an assurance process. So this is the resilience in place. But I do think it is there, just not written out in a plan yet.
Thank you. I think it'd be good to see the maturity matrix updated and actually so we can see where each of the PCNs stands, and that might help with development and support needs as well, because November is a long time ago. A lot has happened since then. Are there any other questions or comments? No, thank you very much. That was very helpful. So that is comes to the end of the agenda for this part of the meeting. I've not been told that there's any questions from the public, that none have been received. So thank you all very much for your participation, and look forward to seeing you again this time next month. Thank you. And I say goodbye to those who are leaving us for part one. And thank you all very much. Thank you. Thank you, Tony. Thank you, Bill. And the recording is coming off.
Yeah, I'll stop the recording now.
Thank you. And we're off YouTube.
Yeah.
Do we want a comfort break, or we have to plough on? Kathy says, yes, please.